children's centre delivery models? Okay. I'll do the slides to fit with everyone in the audience. Okay? Okay, thank you very much. One of the things that we always say about connecting child health services is, you know something? We've landed 12 men on the moon. We've brought them back again. We can even take Mars selfies all the way in Mars. So connecting data that I'm going to talk about is very simple if you begin collaborating with the people around about you. And I've been impressed with all the speakers this morning and this afternoon. And without that data, you cannot make intelligent, evidence-based conversation for the future. So what I'm going to take you is the journey that many of you will now be going on as commissioners, as clinical providers, and even as parents, around how to make sure that the clinical systems connect up so that you get meaningful data and intelligence. It's predominantly about the CHIS system and the CHIS service, the Child Health Informatics Service and the Child Health Information System. It has two functions. There's a requirement on myself as regional lead for NHS England to know where every child is and how healthy they are, predominantly around their newborn screening and vaccinations. But then there's a mandate on myself under Section 7A to make that information available to everyone caring for that young baby, young toddler, preschool-age child, including the parent themselves. And what we've been doing in the last 2.5 years is listening to clinicians, looking ahead and seeing what needs to happen. There are some key facts about child health, mainly that as commissioners, whilst you look after the parents and the individual babies, our role as commissioners is around population-based. But it's also our role to begin offering every parent the opportunity of launching the electronic version of the Red Book. We know since the Red Book was launched by Harlow Printing and the Red Book Board, parents love the Red Book. It's a go-to place, but historically it was always given at the delivery suite when mum had just pushed out baby. She was handed the Red Book and told to get on and understand it. So we need to begin working with mums-to-be and parents to see how this system needs to shift and transform onto a more, particularly the mother, but even the father approach. What's the current state of CHIS system? Many of you would have been involved in around about August 2014. There was a STICE, a serious incident, when it was established that across England, no one knew the definitive caseloads for babies born across England. We had a new birth feed, but we couldn't categorically state that every baby had a responsible health visitor, every baby had a responsible GP or a registered GP. And so a substantial piece of work was undertaken during 2015 and 16, trying to put in place fail-safes, particularly for the Healthy Child Programme indicators of newborn screening, that's hearing, newborn screening, including blood spot, newborn screening, including the new infant physical examination, and all routine vaccinations given to the under ones. And so what we began doing is mending the fractured systems. We also had to look at limited access. There is a ridiculous situation in England that only the health visitor at new birth registration has the authority to see that child's newborn screening data on Northgate portal. So in London, 23.7% of children will be in 2 boroughs by the age of 6 months old. Therefore, quite reasonably, 2 health visiting teams. The second health visitor at the moment doesn't get access to the screening portal on Northgate, and we're trying to fix that. But also, there's an unnecessary 1980s administrative bureaucracy around child health. In London, we spend £9.8 million on Child Health Records Department. 2.5 years ago, the vast majority of it was managed by Band 3 people at the end of a dark corridor, bish-bash-boshing clinical data on the children that you look after without any recourse to clinical quality. It had to stop. This is important clinical data on every child, and we needed to move it forward. And one of the things that's moving forward is the fact it took us 600 years to go from a plough to a tractor. It's only taken us 6 years to go from an analog phone to smartphones. The age of digital technology has now caught up with early years. And so what we need commissioners to do and what we need providers to do is come into the realms of electronic data. Here you see a map before you that was drafted in the 1st of September last year when Health Visiting Services went across to local authority commissioning. I know because in London I sent £108 million worth of health visiting services to 32 local authorities. You'll see there 146 separate small teams of Band 3s beavering away in dark corridors and darkened rooms, trying to load this data in manually. But we've been on a journey with them. The types of processes and events they've been processing, particularly the upper row here, is fundamental. Every child in England born or moved into England should, by the age of 12 months, have 58 data items held on them. The newborn screening and demographic data has 16. That also includes the maternal link. It also includes, importantly, if any Hep B baby is born to a Hep B mum. Vaccinations. Every child by the age of 12 is recommended to have 12 vaccinations. The GP routine check, again, another 5 indicators. And the new, or the developing Healthy Child programme. So there are already 58 data items on that child's record by the time they're 12. Most of them have all of the above, plus what you can see there. Many of them go to the GP with illness visits, local hospitals, health visiting interactions, school nursing. Some of them, including all of the above, will then have a chronic illness, long-term disability, mental health. 2 to 10% of children by Rising 4 are considered to have some sort of intervention linked to a young person's mental health. And at that stage, you're then looking at requirements of multi-agency care. And then a few of them, yes, a few of them, need that sort of complex over and above that. So safeguarding, complex care packages, looked after children and adoption. So all of these children have a growing electronic file that used to be held manually and posted or sent in vans every time they move between health visitors. So we're in a journey to digitalise this. These are just some more of the other types of information that health visitors, clinicians would be collecting on children. There is a wealth of data. As someone said, we are data rich, but I would say, as a commissioner and as a midwife, we're actually intelligence poor around that child because no one's ever collected it together and held it in a central place where the parents can get ownership. So what are we doing? Well, we've got to make this information available to parents, their families, carers, children, and the young people themselves. And we're moving towards electronic online records. Anyone here launched their patient online? Anyone? Go on to the Department of Health website, find patientonline.co.uk and launch your own electronic record. But do not do it at a conference, as I did, because you can see all your historic tests. Don't be prepared to open up your medical file. We each have that. So as commissioners, clinicians, and people who look after carers, you need to embrace electronic records yourself in order to empower patients that the electronic record is secure and safe. So patients online. We need to give information for professionals. Every professional in this room and out there should have a core data set that surrounds the patient, the parent, and the child. And every domestic homicide review I attend, every Part 8 child death review I read, a broken record is implicated in us not capturing that incident earlier. So we need to be doing that. Importantly, at the bottom, items 5 and 6, we have got to begin using the integrated record around fail-safe, because there are children that need that fail-safe at 6 to 8 weeks for their screening results. There are fail-safes to be had at 12 months around vaccinations, just to make sure that they're being delivered effectively. But there's also information services for public health as well. The data needs to go to the commissioners. And as digital data becomes more relevant, then it grows. Yes, we've got 58 bits of data on every child now captured. But in London, we have 136,000 live births every year. And that grows. By the time of 5 and 6, we have 5.2 million data points in London in our under 5 cohort. So data captured then grows exponentially. This is just a slide that we're using to show how, when the data's captured, there's a tremendous effect on the parents' contribution to that. Down the right-hand side there, you can see personal health. And what we're trying to do in the future is look to see how parents themselves can populate. Because regardless of how large or little the public health grant is, some services aren't able to capture that moment of baby's first steps. And so we're beginning to work with parents to understand, how does the parent themselves feed the digital record by ages and stages, or we'll have known them as milestone development checks, so that when they come in contact or contribute to a professional health assessment, they can look at 18 months, 2.5 years, 3.5 years with real live evidence, video, photographs, etc., because the parent might be able to capture it on their smart technology. Obviously, that's useful to public health in so many ways that you've heard previously. The vision is by 2020, there will be a child health hub in every region. We've listened to parents. Parents are quite clear. Capture it once, use it as many times as you need to with our consent, but it's all around creating a hub. So on the blue side there, you can see the hub being fed by healthcare professionals, health facts, the Healthy Child Programme, My Health events, if they're indicated, including, it has to be said, NICU, the neonatal intensive care unit. As a child goes to neonatal intensive care units in many parts of this country, and including many parts of London, my own region, we are in the ridiculous situation in 2017 that NICU cannot share the file with a health visitor because it's in the wrong format. Get real, you're the same organisation. You have a mandate under the Children's Act, Section 12, Chapter 14, to actually buy and use informatics for the benefit of safeguarding that child. So we need to be working within systems, suppliers, to make sure that whether you're a child on NICU, whether you're a woman birthing on Leonardo, whether you're a health visitor using EMIS Web or TTP System 1, you know that when you share that data, as we all do, it will fit together to create a single point of truth on that child. And the whole idea of this collaborative health hub is that data will fit together using technology called open APIs. So What are we doing? Well, London has been very fortunate, and we've got some providers in the room here. London has 23 child health information services, band 2, 3s and 4s. They're doing a fabulous job. And they've been on a journey for 2.5 years with us. And they're mainly moving from manual data entry into what's called CSV, cut and paste. We'll know it as cut and paste, but it's CSV, comma separated value. And from April, they will be launching 4 new hubs across a single platform in London. So every child in London will be loaded onto the child health platform, an integration engine, where all the MATB1s, so notification of pregnancies, are loaded on. Every time a child is born, then it goes through the patient demographic services, attaches an NHS number, and the mother maternal link goes onto the platform. Then from week 3 onwards until 6 weeks and onwards to 42 days, the flow of newborn screening data will come in. And that will mean on the London platform, a single point of truth will be collected, because allowing 23 small services working Monday to Friday, manual processes, just wasn't cutting the mustard for the parents in London. And then 6 days a week, that data will churn using the NHS number and send reports back to the health visiting teams that they can upload onto the child's file, perhaps in real time eventually, but at the moment, it's going to be 6 days a week. And reports will then be sent to the local authority, aggregated reports. There are rules. Someone was asking, why can't local authorities see patient identifiable data? There are laws at the moment that we're trying to overcome, but there's no reason why children's centres cannot get aggregated data around the pregnant women in their postcode area. No reason at all. Let's embrace modernity. And importantly, what we're also doing is, if you notice the amber up there, we're creating a portal onto all screening for every health visitor or clinician to be able to view any child's data in England. So as you receive a mover in, maybe you've at a children's centre and you've got a new child in the area that are a mover in, you can immediately look onto portal and see if that child had their screening done, rather than having to go back to the office. But critical to all of this is the red box. So from April the 1st, there will be no reason why every parent in London cannot launch their electronic parent-held child record. Or in London, we call it the e-Red Book. So it's been field tested in 4 sites at the moment, and another 3 sites are prototyping the screening results. The awe and wonder on a parent's face when they open up their smartphone, which many of them have, or the library, the computer in the library, or the computer in the children's centre, the awe and wonder on a parent's face when they see those vaccinations pop up and they suddenly begin owning their child's public health indicators. It's amazing to watch. It really is amazing to watch. So this is going to be tested and validated. We're just in the final process of that. This will become a blueprint. All the technical solutions, called open APIs, all the build solution, called OBS 2015, Outcome-Based Service Specification 2015, will be sent to every region and, importantly, every local authority commissioner. Because part of the problem at the moment is, whilst local authorities are commissioning health visiting, what they are not doing is they are not commissioning the system that allows you as health visitors to robustly manage it. In 2 parts, one part of London and one part of England, health visiting has been tendered without any contractual regard or due diligence on a clinical system. So there's absolutely security about TUPE and the staff, nothing about the clinical system. So we have got to begin working with local authorities very quickly to say, when you're commissioning early years, they must have an N3 connection, they must have a clinical system, and that clinical system must connect with every other part of the early years systems. Otherwise, you're delivering health visiting without technology, and you're delivering it in a vacuum. So all of this is going to be launched as part of reflections and guidance at the end of March for anyone that wants a pack on how to commission the technology of early years, as opposed to the 2 or 3 paragraphs that we're currently seeing in the health visiting contract. Okay. So thank you for listening, and I'm looking forward to meeting you all on Twitter as well. We're doing a lot on Twitter on this, and get logged on to your Patients Online.